So I wanted to welcome everybody and thank you for your patience. If you hopped off and you're going to hop back on, thank you so much. Thank you, Niva, for being so patient. And so I am Erica Vonderleef, and I love helping women build simple daily habits to help balance their hormones and reset their metabolism so you can shed unwanted weight, stubborn weight, and just feel better, have more energy, sleep better, and optimize your health. So I have Niva Herzig today, a pelvic rehabilitation specialist, and we are going to be talking a lot about pelvic floor dysfunction. So what I'm going to do is I'm going to have you, Niva, just kind of introduce yourself, because you can do a much better job than me in terms of all of your qualifications and what you specialize in. And we're going to be talking about some really great stuff today. So I'm really excited. And I know a lot of listeners are excited to hear what you have to say. So go for it.
Awesome. Thanks, Erica. And thanks for being a super IT lady right now, person. So yes, my name is Niva Herzig, and by licensure, I'm a physical therapist. I've been a PT for, I don't know, now it's been a lot of years. I never thought I would get to that chance of saying that, but it's been since 2003. And in school, I had this, well, even before school, I had this obsession with pregnancy and everything that went around with it. And then I found out about this thing called the pelvic floor that most people don't even know that they have. I was the one person out of a class of low 40 students, 42, I can't remember how many we were, that said, oh my gosh, there's a pelvic floor clinic as a student for an affiliation. I'm taking it. Nobody take it. And I took it and I fell in love. And I moved to Manhattan after that, and I searched for a job that will fulfill me. And little did I know that I would just take it into different ways. I mean, I'm a pelvic floor therapist. Some people think I'm a urologist, gynecologist, colorectal person, an exercise specialist, all of it. At this point, I've gone into health coaching. Now I'm in a sexual health certification program. So I just like to educate myself. But I'm still a PT at heart and treat. I see all people, all genders, but my focus is pelvic something. A lot of times it's also some sort of mystery what's going on. So a lot of my patients are dealing with pelvic pain, but that may or may not have to do with pregnancy. And like I said, I do treat people who identify as male and female. I live in Bergen County for the past about 13 years. I moved here for some reason, but to open up a practice was actually my main reason. And I opened up in Englewood, and I've been in Englewood as a solo practitioner with other employees now, very small, one other employee right now. I'm a mom of two children, a boy who just turned 10, and my daughter is almost 13. So I'm in that next phase of life with them. And I'm a dog mom. I have a Roger Labradoodle who just turned 4. So everybody's having birthdays.
Wow.
And a little about me, I guess, personally, I'm a person that probably did the least amount of exercise and had any interest in nutrition. And I've grown to be, I think, crazed about it. I love functional people, and I love integrative, and I love talking nutrition, and I love talking exercise. And I, more than anything, love to take people out of a fear-based and myth-based thought, and create a space for them to say, well, why don't you think you can do a crunch? Like, who told you you can't do a crunch or a squat, Who told you you can't exercise? Who told you this? Things like that. And what's the reasoning? And a lot of them are just scared. And let's try it. Let's see what happens. You're in a space, I can help you and guide you. Let's move on. So, yeah, I guess that's me in a nutshell. I don't know. It's enough talking.
Yeah, so there is hope for a lot of people. And I don't know if there's specialists or doctors telling people this, that these myths come into play, or they're just talking with their girlfriends or their friends and they're saying, I have that, and everyone just assumes that since it's so common that it's normal. So I know we're going to bust a bunch of common myths or truths. The main three things that we said we were going to touch on were kind of like the postpartum exercise myths or truths. You know, what kind of exercises can you do or can't, or you feel like you can't do? Urinary incontinence, I think, is a big one. I don't know if that, you know, and like you said, male or female, we can touch on that as well. And sexual health, which I think is a really big one for people.
For a lot of people.
Yeah, yeah. And I think that there are so many myths behind these three main bullet points. And yeah, I would love to touch on those. And then obviously, you're not going to be treating anybody over the course of this call, obviously giving us some tips. And that's why we're looking to you as a specialist, as a practitioner, so we can go to your clinic and, you know, see what you have to build on how we can improve upon these things as well. Because I think some people just think, I didn't even know there was something I could do about it, right? Except for
Absolutely.
right? I mean,
Yeah.
I don't think that's the solution for a lot of this, you know, sometimes it's not just
And I think a lot of people say it's a one size fits all. So if I have X, Y, and Z with whatever the label is, then I need to do what that person did. And sometimes that's true and sometimes that's not. But especially when it comes to body work,
right.
we're all individual. You brought up a really nice comment. Well, I guess it's not so nice, but who's telling people not to do. And I actually apologize to a lot of my patients. I know I did it 10, 15 years ago when I started because that's what was available to us as well. So I hope out of everything, I think people realize that times change, you know, medicine change, you know, therapy changes, everything changes as we learn more. And that's what you want. You want somebody that is continuing to learn more, right? Staying up with everything. So it's, but unfortunately, to get rid of the old material, let's say from the internet, you know, where everybody searches, and I do too. Yeah, I mean, listen, I do it. You know, I just called out a physician by something that I searched, but it is what it is. But you know, the information is there. So I also want to create a good relationship, not to tell somebody, no, they're wrong in their thought, but why we have changed. Or, hey, has that way, has not doing something worked for you? Well, most likely they're going to say no, because that's why they're seeing us, right?
Right.
So maybe let's try it a different way.
Right, right. Okay, great. So why don't do you want to start with postpartum exercises? Because I know, okay, so a lot of people that I might see, whether they have a C-section or they don't have a C-section, or maybe they don't want to have a vaginal birth because they're worried they're not going to ever be able to control their, you know, have any bladder control after that. Oh my gosh, I can't do a jumping jack. I can never, you know, there's certain things that you think you're never going to be able to do postpartum. So,
yeah. So never say never. We don't really know, right? And some people, you know, clearly there's tons of surgeries out there for some people, but not for every person. And surgery, you know, as much as a surgical consult is welcome, always, it's not going to change how you're actually doing a jumping jack or a jump rope or running, or it's not going to make you stronger if that's what the case is. But I think the assumption is, one is I need to do Kegels, and they told me only to do Kegels. And my response is it's more than just Kegels. And also it's more than just your strength. Let's look at coordination, look at endurance, look at your breath work. So it is one of those, oh my gosh, that is common. You're not the only person dealing with this, but it's not a norm that you have to live with. And it's not necessarily only a vaginal delivery, it can be any type of delivery, and it could be not related to childbirth as well.
right.
We see a lot of, for sure, stress incontinence with athletes, basketball players, gymnasts, that force that's on their body, the pounding on the ground, something like that, or they've created such strong every other part of their body, but maybe their pelvic floor and their diaphragm, their breathing techniques is off.
Wow. So you have to do like a pretty thorough examination.
Yeah.
Right?
If you're only wanting your PT or practitioner to only look at the pelvic floor, then you're missing a part of it for sure. Absolutely.
Because there's diaphragm and
Yep. There's
other.
diaphragm, there's your abdominals, there's like I said, the coordination. So great, I can contract my pelvic floor. Awesome. How about what happens when I cough? What happens when I stand up? Do I have that same type of contraction?
Mhm.
And I think some people say, oh, well, I just do those Kegels, which I now call pelvic floor exercises. I've moved away from the word Kegel. I just do them in the car. And I said, that's great. You created some time you found time to be accountable, right? But um, can you practice your endurance there? Do you have time to practice longer holds? And I think on the vice versa, when you maybe go and get checked out the gynecologist or your physician, it's a very quick exam. And they say, okay, just do it for 10 seconds, 10 times, and you'll be good. But maybe that person can only hold for 3 seconds. So what happens to them after 3 seconds? What else do they recruit? Um, but you want to look at their posture as well. Not to say good or bad posture, just where do you find where your feet on the ground, like where is that weight bearing space, and when can you connect to your pelvic floor a little better? What happens if we do a little hop? Anything like that. So we can practice in that. And I'll sometimes also use a biofeedback, which I know a lot of people have heard the word biofeedback, which is a tool we use to get visual and auditory response to gain that motor learning and that muscle control.
So that's actually something that you would hook somebody up to in your office.
Yeah,
Yeah.
so it's a tool. You can do it either by external, which we just call them surface EMGs, like they look like little sticky electrode type of things.
Mhm.
And you could put them externally by the pelvic floor, or you could put an internal sensor. But it's not necessarily my first. I mean, I know a lot of people, like I said, that's definitely an oldie technique. I like to feel with my hands if they allow me to do a pelvic exam because I know exactly what their how they do it, what their
Mhm.
go-to is, what their
Mhm.
strategy is.
Wow. Yeah. So you can, what muscles are connecting where and what should be flexible.
Yeah. Yeah, I can change the right or the left. I could see, where is their cheat level? What other muscles do they recruit? And it's not to say that the pelvic floor doesn't live alone. Like if I stand up and go for a jump rope, it's not just my pelvic floor that's activating. What are my legs doing? What are my abs doing?
Right. Right.
So it is
So
it is a whole person, no matter what.
very detailed oriented and more than just
Yeah.
do these Kegels. So there
Yeah.
is hope for people to do exercise and they shouldn't just say, is it detrimental at all for people to say, I'm just not going to do those exercises? Like, I mean, you would,
Choice.
yeah, to avoid doing those, why, you don't have to avoid doing those exercises if they're things
Yeah.
you.
So one of the questions I ask people, because not everybody that has leaking, even if it's stress incontinence, wants to exercise, right? There are people, I'm not going to say that. So for example, some people just come in and say, I sneeze or I cough or I
Yeah.
laugh, right? So it's not even exercise based. Or, when I'm walking, or when I pick up my grandchild, or when I pick up my new baby, right?
Right.
Um, but I want to know what they like to do. So if they say I hate exercise, I don't even call it exercise, right? I was like, oh, okay, how many times do you get up and down from a chair a day? Oh, I do that all the time. Okay. Can we maybe use your pelvic floor for now to remind it to work when we do something like that? There you
Yeah.
go. Bam, 20 times in a day.
Right. Right.
Right. So at least it's something. It's kind of going back to the car. I mean, I don't want to lay there and do Kegels either. It's one of my most hated thing with a patient in the office. Like 1, 2, it's boring, right? But it has to be done. I get it. It does have to be done, but let's make it a little bit more fun and something that you like to do.
Well, and then is it detrimental then to just like, okay, I just have to go to the bathroom a gazillion times a day so that I'm not caught in a situation where, pee my pants all the time, I mean, I don't think that's probably a normal or healthy way to go about things either, right?
Correct. So then we're coming into what you're training your bladder to do. And possibly moving into also an urgency and an urge-based issue. But let's go back to that stress incontinence. The common person says, well, I'll just still leak even if I go to the bathroom right before, fill in the blank of the activity, right? So first of all, what you need to know is the bladder is never 100% empty, nor should it be, just like our lungs, right? There's always something a little bit. There's a level that we say it's too much, it's retention, and most likely they're just very little. But if they had a cup of coffee right before they went to their HIIT class, okay, yeah, the bladder might be a little bit more annoyed and you might see leaking. So we have to talk about some triggers and stuff. Now it's your choice, right? I know I personally don't drink coffee before I go for a run because my bladder will fill and I go for long runs. So can we adjust the time? Again, what are you willing to do? Is it detrimental? No, in the long run, though, you're training your bladder to be kind of this small bladder, right?
Right.
So if I make this analogy, if I fill my bladder up to 1 cup and I pee, and I fill my bladder to 1 cup and I pee, and I fill my bladder to 1 cup and I pee, the bladder only knows that stretching. Now, the other side of it of detrimental, so you're not detrimental, but you are also training it to have more and more urge. If you go the opposite way, I'm going to fill it, fill it, fill it, and hold, hold, hold. There's the other part of it. That's going to annoy it too.
Okay. But it's adaptable. It is adaptable.
It is
But
definitely adaptable.
I can see
We're
pros and
adaptable.
this idea. Yeah. To just fill it a cup empty. Fill it a
Yeah.
cup. Right.
But to ask you asked the question of about is it detrimental? I mean, if you don't do anything about leaking, is it detrimental? No, it's not. Not that I know of. It's not going to cause anything medical down the way. I mean, some people don't care about it. Some people are fine. You know, some people say, I'll just wear pads. And those people are, you know, some people say, I'm not doing surgery and I'm not doing PT. Like, you're not touching me and I don't want it. Right. I'm sure there's tons of those people.
Right.
That's up to you. I mean, I tell a real story of my sister. My sister straight out chose not to do PT. I didn't talk to her for a little bit, but don't tell her. She doesn't know that. I just didn't, I don't bring it up. I am a little hurt, but she admitted, she's like, I'm not going to do anything. But I also don't think it solves your issue if you don't know how to jump correctly. If you know, if the activity is not done correctly or well enough, then maybe you'll still one day leak. But it's you know, down the line, I guess it's not detrimental. You can't like leak yourself to something.
Yeah, it's not something that's going to really get any better.
Yeah, I mean, your skin is probably going to be a little yucky, and you know, I'm not sure that like other areas are going to be as happy if you're just sitting in urine a lot, but somebody else's choice, not mine.
Yeah, it's everybody's personal choice, right?
Yeah, yeah. But most people don't leak a whole thing.
Okay, okay. I will need surgery since I'm leaking. So they're not always a candidate for surgery. There's definitely things you can do to help avoid that. And it's not normal.
Yeah, I mean, surgery is not the only option, but surgery is definitely an option. I'm not here to say surgery is wrong. I've actually treated people who've had surgery, right? Yeah. And like I said, my sister that was the choice that was right for her. And there are some people, I mean, I've spoken to some of the urologists I work with, you know, that person that's still like, everything seems to be fine, but it's that 1 cup of coffee that leads them. Maybe they'll do, but again, it's an irritant. So I'm not 100% sure that surgery will 100% fix it. You know, everybody wants the fix. Everybody wants the fix and they want it now.
Right.
Right.
Well, and I want our listeners to know that it doesn't have to be surgery, and it could definitely be more than just Kegels. You know what I mean?
Yeah,
there are
absolutely.
practitioners like you that are specializing in helping people do more without just saying, okay, this is just how it's going to be.
Yeah.
There's way more to it, you know? So,
and occasionally we will see, so with incontinence and a lot of these postpartum issues that, you know, I think I listed for you were, most people assume always a weakness, a loose pelvic floor, but we will see in a lot of my patients, especially the patients on the pain side, but we see this hypertonic, overactive pelvic floor muscles. This is sometimes what we see in the athletes. If you think of a muscle in the length tension curve, a muscle that's like too loose, kind of lax, low tone, and a muscle that's over tight are both weak muscles.
Okay.
But if a muscle is like, kind of doing guarding, we do have to open it up before we re-strengthen it.
Okay. So it could be tight and weak.
Yep, absolutely.
And you find that common after delivery?
A little less after delivery, but at other times, yes.
Okay.
But it depends. It is something that I'll still look for no matter what. I have to figure out which way, because then the treatment method may change.
Yes, and that's different than just giving somebody Kegels.
Go do Kegels. Right? Yes.
So that's important that they get checked out by somebody like you, so that you know that you're doing the right thing to the right muscles.
Yep.
What about age? Like, does your pelvic floor and the muscles change as you get older?
Sure. So, I mean, you probably can chime in a little bit hormonal aspect, right? Our body. I mean, one of my mentors uses a term, it's a new season, right? It's a different season, and we have to adapt to that new season. So body changes, and for sure, we could all see our skin changes, how much we can or cannot exercise may change, the food we eat changes, the hormones will change. So for sure, as a person who has female parts, let's say has no surgeries, nothing's been not non-functioning or removed, no hysterectomies, and has ovaries, but overall the estrogen is going to start reducing. And now we're talking about, I'm not going to talk about something like bioidentical hormones. I'm talking about like localized hormones. And so we can see something, especially with perimenopausal and menopausal women, that we now call genitourinary syndrome, sometimes genitourinary syndrome of menopause. But for sure, the tissue is thinner, the elasticity is gone, that oomph and plumpiness of the muscle, it definitely can go away.
And that's not necessarily, okay, so now we're talking about like the vaginal area, right? When you're talking about the pelvic floor, and we're kind of getting away from incontinence and talking more about sexual health.
It could be both on that. It could definitely be either of those. Yeah.
So you're talking about the skin of the vaginal canal kind of thinning and getting maybe even dry, right?
Yep.
With the decrease in estrogen.
Yeah. But some of the women won't even complain about dryness. They might they might have just urinary symptoms. They might say, I'm leaking more, or I'm having more urgency. They might have those sexual complaints as well, one or the other or both. And this we could see, and if you want, I have a pelvic model next to me, so I can show the pelvic model, but this could be in the more external genitalia, in the vulva. So we have our genitals, the labia, the clitoris, that's all the vulva. And then we go towards the entrance, the vestibule, and then we go into the vagina, the inside. And so sometimes the estrogen needs to be more on the kind of external area as you go in, and sometimes deeper in, or both. Yeah.
So like a topical estrogen that you're talking about, just like a...
Some might need that, yeah. But we also use oils, like in the coconut oil. It depends on the person. Again, it really will depend on somebody, but there's definitely over-the-counter moisturizers, lubricants, absolutely. They need, I'll talk to them still about pelvic floor exercises, because we might need blood flow there. If they're open and willing, and we're going into sexual health, vibrators push in a lot, and you don't have to use them for pleasure, just to get that blood flow in there.
So the skin is thinner and there's lack of blood flow. Is it so that doesn't necessarily have to do with muscular dysfunction, or
it can go in, it can overlay into the muscular dysfunction, because everything has the fascia over it, right? And if the fascia is not happy, it's kind of tightening over the muscle, and now the muscle may not react the same way. So it depends.
And that causes pain.
Cause pain, can cause urinary symptoms. Yep.
Yeah. Yeah. Okay. All right. So you listed a bunch, I'm looking down at here because you listed a bunch of bullet points under sexual health. And we touched on them already in terms of lubrication, lubricants. Once I get into those perimenopause and menopause years, forget about touching my vulva or vagina. Oh, because it's so painful. Is that why you listed that? Yeah, right. And
that or the people are saying like, oh, that's it, I'm done, I'm shutting off.
yeah.
Like, I'm loving it. It's funny. So I got into pelvic floor. I really wanted to do everything pregnancy and postpartum, and slowly but surely, my life is changing too.
Yeah.
I mean, I love it when my 50s, even now more 60s, 70s people come in and they want their sex life. I love it. I think it's great. I'm not saying anything wrong with people that don't choose it, but it's a part of their relationships, or even if they're single, it's, the people I've seen widows and they're like, I'm still, doing stuff on my own. Like, that's great. So I wrote that, as kind of the myth, well, now I'm at this stage of my life. Let's not talk about that. And no, they're actually telling me like, how come some of the doctors are not asking me about sex?
Yeah.
Sex makes people uncomfortable.
Right. Because they assume, I don't know, that they're getting older, and I don't know. I have no idea. So that's good to have that open dialogue with people who, so one of the things I posted when I was telling my Facebook group about this talk is that people are struggling with this stuff and nobody wants to talk about it. Right.
Yeah.
And who are they going to talk to about it? And who, I don't know. I mean, the medical doctors maybe have some advice. I don't know if it's mostly probably bioidentical hormones. It obviously depends on if you're going to a more medical oriented doctor or a functional oriented practitioner that has, some other options like this. I do talk about it with some of my patients as well. And there's definitely I feel like a really big need out there for people like you, for practitioners like you. Mm-hmm.
But even like, let's think about nutrition again. That's another cup of, your cup of tea. I mean, there's tons of great foods to help us lubricate. What about all those yummy fatty foods, the avocados, the salmons, the nuts? Like, those are great for us as we age. They provide some of that lubrication, right? Yes, I think it's a kind of a two-way system. A patient walks into a practitioner's office, MD, DO, PT, chiro, whatever, acupuncture, and they want to bring it up, but they are scared or ashamed, right? And then the practitioner then says, well, if they didn't say anything, why do I ask, right? So I do have these questions on my questionnaire. Whether, they all kind of get the same questionnaire. So if they're coming for incontinence, there is a sex question on there. If I see it, I'll ask them, you came for your bladder. Would you like me to talk to you about this? Yes, no, maybe so, maybe later. Okay, no problem. So it's also, I think it's up to us as practitioners to open the conversation and ask for permission. Do you want to talk about your sexual health?
Right. Yeah, I think I'm going to talk about it more because, there's the stress component, the mindset component, obviously the hormonal component, and then, and
trauma, your trauma from other, some people say this whole sexual dysfunction or something, but let's talk about like, maybe you had a bad relationship and somebody told you you were bad in bed or something. I don't know. That's going to go on with your next partners.
Right.
Yeah, that's why I loved going into the sexual health counseling. I thought it would, no matter what I do with it later on, that it's going to bring just happiness to my people.
Yeah. So you also have a certification in sexual health counseling?
Not yet. I'm working on it. I'm this weekend is my 3rd month, and then it goes into next year.
Oh, wow. That's great.
Yeah, I'm excited.
when you go to your gynecologist, your medical doctor or whatever, besides not really feeling comfortable talking about it, they don't have the time allotted to speak to
Right.
patients about it either. Yeah. In your
Yeah.
little, like
And
maybe
it's,
5 minute slot.
yeah, and training. It's not spoken about a lot of these, especially on the pelvic pain side. So I do have a referral base of specialists. Um, I love my general OBGYNs, urologists, all that. I mean, but I know who has what specialty. Just like, don't send me somebody with a neck issue. I don't want to see them. Not my thing. I'm not going to help them. I will say, go somewhere else. Why don't, I'm not your person. So not everybody is the person to treat. Not every gynecologist needs to treat menopause, right? Or sexual dysfunction or bladder health. Depends on what your thing is.
Yeah, but I have a lot of patients who have maybe incontinence or commonly maybe interstitial cystitis or whatever. And so their only go-to person would be urologist. So
Right.
that's maybe not necessarily,
But not
like,
all urologists treat interstitial cystitis. That's a whole different topic.
yeah. So, like you said, you can see the medical doctor, but the medical doctor is not the only practitioner
No,
that's
you
going
need
to
a
be
team.
overseeing this type of conditions and care. So,
Absolutely. I mean, a team of resources is what makes, I think, the patient rich, right?
right, right. Super important. Yeah.
Support and resources.
Mm-hmm. Okay. And then you know what? There's one last one. Oh, you know what? There's two here.
Yeah.
Okay, so myth or I want to be uh cognizant of your time too. The
Okay.
last two up here is it's common for PIV, penis and vagina sex, to always hurt after childbirth, and burning in my vagina is an infection. So that's something that you see a lot too, that people think is normal or common or whatever.
Or they think it's infections all the time.
Yeah.
So let's talk about the penis and vagina. Well, it hurts a little bit. That's okay. Or I just kind of, close my eyes, or they told me to have a glass of wine. I need to relax.
Oh
And then
gosh.
most people end up avoiding. I mean, who wants to have painful anything, right? But there's lots to do for it. The burning genitalia. One thing is, I think a lot of people I see a lot of people that end up coming in that they think they have bladder issues. They have interstitial cystitis or something, and I actually do need to refer them to a gynecologist. There is more vulvovaginal issue going on along with their pelvic floor, right?
You need
So
to rule
it's,
that out
again,
for sure.
yeah. And but yeah, so not just because there's burning, like a burning fire sensation in the anywhere in the genitalia area or the vagina, doesn't mean that it's an infection.
Mm-hmm. Mm-hmm.
For sure. It can be a sign of something else. But yes, you do need to rule out infections. Like that's not wrong to do. Get a culture, get a urine test, get, whatever is needed to at least rule that out. But
Mm-hmm.
most people go through this cycle of, I got another one. I got another one. They go on antibiotics and the antibiotic helps, right? But the antibiotic has an anti-inflammatory component that helps them. It's not
Mm-hmm.
because they had a bacterial component.
Yeah, but
And now with cycles, let's say they did have infections. A lot of people do have a lot of infections, right? And the cycle goes that you have an infection, it gets better. You have an infection, it gets better. But eventually it's not getting better all the way. The infection's gone, but you're still feeling this like remnant of that, you know. And then your muscles react as well. So which came first, the chicken or the egg? I don't always know because I meet them later on. But if I keep punching you in the stomach, your stomach is going to tense up, right?
mm-hmm.
And there's
Mm-hmm.
that pelvic floor dysfunction.
Uh-huh. So it's not necessarily repeated infection.
Not always. A lot of
Yeah.
times it's not. A lot of times I'll ask somebody, were they actually cultured? And no, they weren't.
Yeah. Well, you had this before. Let me just give you this antibiotic again. And they don't usually, they might not have been cultured.
Right.
Interesting. Yeah. Yeah. Okay. And I know, like, after childbirth, I've had people that have had, they'd have torn normally, or,
Episiotomy.
the episiotomy, and they would chalk the pain up to, having that done too. It's scar
Yeah.
tissue, or, So it could be a lot of different things that you
Yeah, it
just,
could be that. There could be a hormonal after birth as well. Just because you had a vaginal, let's say, delivery childbirth method, your muscles could still be a little bit tight and just unhappy. So yeah, that is possible. I know a lot of people, even actually during COVID, this happened a lot, maybe because people were home and they were able to do telehealth fairly easy. They were calling me like 2 weeks out, and I said, you know what, let's, even I'm not doing an internal virtually, um let's talk, but let's maybe not go right to, all these pelvic floor. It is just good to start turning on your muscles, but you don't have to go into an aggressive. A lot of people that they see some incontinence immediately postpartum, a lot do better in the first month just naturally with things just getting back in tune, right, on their own.
Mhm.
So
Mhm.
not everybody ends up needing PT, but I think it is great to have some sort of assessment postpartum, because we are, it's like you train for this marathon, and the marathon is the pregnancy, right? And then you run through the finish line, you have a delivery, whichever method. All right, bye, you're done.
You know what?
See ya.
Right.
See you next year. See you in 6 weeks, and then see you next year. But the
Mhm.
6 weeks, I think, yeah, they're checking their muscle. Okay, they contract once, great. Okay, that's good. Your uterus is feeling smaller, went back into place. You're
That's
not
it.
bleeding. You are bleeding. It's a very general. What happened to your ribs? What happened to your hips? What happened to your shoulders? Your body changes.
So you like to see women definitely postpartum to check them
Yeah,
out.
sometimes I just see them
Yeah.
one time. I just saw somebody a couple months ago. I
Mhm.
mean, they call me, they say I want to come in. They want to feel free to go into their exercise program, for example. They're scared to go back. They just kind of want that clean bill.
Right, right. Well, and I know every issue is going to be different, but if somebody is having symptoms or problems, the normal course of care would be what? So for our viewers would be obviously you get an assessment and then people return for exercises, how frequently and for how long?
Yeah, so we evaluate, we do in my office, the PTs evaluate for 1 hour. We take a very long history. We listen to what's going on. And then we do an evaluation according to what we hear. So sometimes it's right away a pelvic, sometimes it's abdominal, sometimes something else. And then most people, because we do all one-on-one care, and then our follow-up appointments are 45 minutes, we do once a week. So if it's a highly exercise-based program, I send them off to a few weeks on your own, come back, a few weeks on your own. If they need more hands-on, whether it's manual treatment, manual therapy, so I do a lot of internal work with my patients, I do a lot of external work, then we're bringing them in about once a week. So it
Mhm,
depends. The
mhm,
time varies person to person. So incontinence may be different than, diastasis is different than dyspareunia, which is painful intercourse.
mhm,
Um, some of those people do, 6 to 8 weeks, some do 6 to 8 months, some do a year.
mhm. Yeah. Yeah, but you know what? This stuff's really important. And I know for our viewers, I hope that this has given people like a lot of information and basically hope that they don't have to feel,
Yeah,
or suffer or feel a certain way.
absolutely.
And that there are practitioners like you that can really dive deep and find out what's going on so that you feel better. But like you said, they
Yeah,
have
yeah.
they have to want to, right? I mean, it.
And most do. I mean,
Mhm.
I think pelvic floor PT is definitely, I mean, it's hot. When I became a PT, I mean, there was really so few of us, and it's for sure blown up, no doubt.
Mhm.
It was hard to find a clinic back then. At least now there are, but it depends. Like my clinic, it's all we do.
Mhm.
Some people like to do a little bit of both. It depends on the person. I totally honor each person in their own clinic.
Well, and let me just tell our viewers that you really are specialized and an expert. You have been doing this for how
Mhm.
many years now?
Since 2004, so just about 17 years. 17
Yeah.
years.
Yeah. So if you're watching this,
Wow, it sounds old.
Niva is you're the go-to, right? You've been doing it a long time. You know what you're
Been a
doing.
while.
So if you
Most
could
days.
let the viewers know how they can get in touch with you,
Yeah.
and any other information. I know that you had this PDF about the myths, and we talked about it today. I don't know if you wanted to, have any special.
You could definitely post that up. I'm happy for you to share. It was really, I mean, they were all falses, basically. They were all myths. But I'm happy for you to share what I thought were common myths that, we would talk about. So my practice is called Core Dynamics Physical Therapy. I'm in Englewood in Bergen County, Englewood, New Jersey. Like I said, it's myself and another practitioner. And so we're in Englewood. I'm also on Instagram and Facebook at Core Dynamics Physical Therapy. I am on Twitter somewhere, but don't look too much for me. I don't post that much there. And I am also happy, and I could share this. I know we ended up not sharing this, to give a 15-20 minute free consultation with Samantha, our newest add-on to the clinic. For somebody, so I can give you the paperwork. I don't know. You can pick. You can randomly pick somebody or figure out how to give it to somebody, or where they could chat. You can ask for a few questions. She might be able to give you a tip on something. My big disclaimer is it's not an evaluation and it won't be a treatment plan, because that does require. I'm very adamant about that. That I don't want to just give somebody, here's an exercise, because everybody is so different.
Right.
But for sure, if they have a few questions, to chat with her, if she thinks she can help, or if the clinic can help, and what maybe some thoughts are.
Mm-hmm. Yeah, because
Yeah.
I do like a 15-minute discovery call with people who are curious as to what I do as well. And I think
Mm-hmm.
it's important. I don't know if you do that with everybody. I'm just saying it's important to know if somebody's the right fit. If, it's not, again, you're not telling what you're supposed to do. You're just kind of going over, what the possibilities are, and if they could benefit, if you could, be a right fit to help each other. So.
Yeah. Right now, my office works without, it's just us, the therapist. So there's no admin. So one of us is always ending up calling. So it's kind of a discovery in that. If they have questions, they ask us right there.
Yeah.
So we can already, and most people, whether think about or evaluate right then. But yes, I definitely honor that.
Mm-hmm. Mm-hmm. Well, thank you so much. I know it's late, and I
Thank
know
you.
it's probably, yeah, it took us like, oh my gosh, so long just to
Okay.
hop on this call. So thank you so much for being patient
No,
with my
thank you. Thank you for inviting me.
and we'll also post your information. I'm gonna post, or you can even comment anything when we finish this up in the Facebook page, and then I'll share it to my other pages as well.
Awesome. Thank
All right.
you.
Thank you so much, Niva. Have a
Thank
great
you.
night. Thanks,
Thanks.
everyone.
Good night.
Take care.
Bye.
Bye-bye.